aspect in the whole scope and cascade for TB and HIV. So, so this grant is a core grant under PEFA, and it's called, it was given a name, Implementation of Sustainable Laboratory Quality Systems for TB and HIV Epidemic Control in the Republic of Kenya. This was a 5-year grant that started in 2020 and has been running till to date, and it's ending in 2025 September. So our focus has been at the national level, laboratories, and key for this meeting is the TB National Reference Laboratory and the KEMRI Kisumu TB Laboratory. We are looking forward to enlarging that scope in the near future, and I think efforts are being done through the national program and NTRL to incorporate the 3 regional labs and also the Walter Reed Kericho laboratory. So that will also be part of the above site laboratory for culture testing. So part of the functions for that lab program was to provide sustainable quality laboratory network systems, and with that regards, the focus is around guidelines, around systems that are for reporting, data system, and also ensuring that the capacity for oversighting these other diagnostic scopes are also available at the national level. Number 2 is to work collaboratively with the Ministry of Health and through the NTRL and NTP to ensure that whatever decisions we are making on implementation are all agreed upon the entire program, so that it becomes country-owned program. Then in addition to that, we also have support for scaling up. These are diagnostic activities or policies that have been established at the national to ensure that the implementation is cascaded down in the counties. So the key areas of interest for this grant has been to strengthen the quality assurance and quality management systems, majorly focusing on infrastructure, certification, equipment, maintenance, and also the accreditation scope. So we have various accreditation scopes that we are supporting both at national and at the KEMRI TB laboratory. We also support procurement of essential supplies. These are supplies that are dedicated specifically for certain interests like quality aspect that are not routine supplies supplied by the KEMSA. Then we also provide technical assistance with regards to programmatic and DRTB surveillance activities. We also support the HRH. This with regards to staffing, and majorly the KEMRI TB laboratory, and also a few staffs at the NPHL laboratory, reference labs. We also support strengthening of data system and surveillance system. This with regards of establishing of systems that are coordinated at the NPHL laboratory, NPHL or the DLS department. Then we also have support to development of guidelines and manual, specifically for TB. We've been supporting development of the lab network operational plan and the TB biosafety guideline manual. Then there's also capacity building. We provide training to the laboratory staffs, both at the national level. Those are the NTRL and the KEMRI lab staff. In addition to that, we have light lifting support. This is with regards to support to issues to do with generator, toners, things that are helping the daily routine works to continue within the laboratory, national laboratory space. So just to highlight key areas that we've supported for quite a number of years that we've been around, one scope that we are so interested with is the quality assurance. And with regards to that, through the NPHL, the national laboratory system established a quality a PT providing scheme, which was named KNECAS, and it was accredited for the 17043 scope. This is a scope that now our national labs are authorized to produce panels for tests that are done in country. That is a local capacity that we know that will eventually result to a sustainable way of ensuring that we have that capacity locally rather than buying panels from outside. With regards to that, we have a number of outcomes of what we've achieved so far. NTRL specifically has been able to cover the PT support for 205 gene expert sites. However, we have a deficit of some percent, that's about some 13%, which is associated with our access to private laboratories that are also testing gene expert. But through the support of NTRL, we are working hard to ensure that as we go along, we ensure that we saturate the entire scope. We also recently started the PT for microscopy. This has also been ongoing, and currently we are estimating of about 500, capacity of 500 facility. It comes in with a lot of challenges because the kind of volume of work that is here is quite enormous, but NTRL has been trying to push, and we are looking forward to come up with strategies to ensure that sites are also reached out, or how well can we scale it up to ensure that we optimally get that service, and also NTRL have an oversight for the microscopy component. And this comes in addition to what you're currently doing in the county, which is the blinded rechecking. This is just to supplement, but not to say that we are doing away with the blinded rechecking. Then for TrueNut, TrueNut just came in a few years back, and we were procuring the PT. However, NTRL has gone ahead, and we were able to generate our own local PT materials, which were piloted in 23 facilities, giving us about 60% coverage. And their results, the analysis has already partially done, but we are yet to finalize that to ensure that we produce a report. We are working with NTRL to ensure that is done. Another addition is that through innovation, the NTRL lab has also started working on EQA material or IQC material for TB-LF-LAM. We know that globally right now there's no clear material for testing, for checking the quality of TB-LF-LAM. But NTRL did highlight that they've started working on a material, of which we also tested them on 23 sites. And also the results, we are yet to analyze finally, but from what we found is that we also saw that they could help us to really run IQC within the facilities that are currently implementing LF-LAM, despite the challenges that we've also get from the facilities. Then there's a component of infrastructure, maintenance, and certification. This is also covered for the two scopes of the two labs that we are currently supporting. That is for KEMRI. So in KEMRI, we are supporting the infrastructure, that is the biosafety level 3 certification, and also the indirect cost for the space that the lab is using for the MOH. Highly to notice that KEMRI lab is also currently supporting the Ministry of Health for TB diagnostics, and I think through NTRL, there's an MOU, and they're actually putting a lot of efforts in that laboratory to ensure that it also helps to cover surveillance on the other side of the country. NTRL certification is supported under GF, and that is part of the AMREF Scope 2, but that support is purely from the GF component. We have equipment maintenance. So for equipment maintenance, we are supporting service contracts for essential equipments, and this is both for NTRL and KEMRI Kisumu. Then accreditation support. Under NTRL, we are supporting the accreditation for ISO 15189 and also 17043 with regards to PT production. At KEMRI, we are also supporting the SANAS accreditation for the same scope of 15189, and also supporting the complementary trainings for both laboratory staffs. With regards to support of TB programmatic and surveillance activity, we support workshops and meetings, and this is to support the staff to be able to attend these meetings. This is both for KEMRI and NTRL staffs. For human resource, we are supporting KEMRI and NPHL at large for salaries for a number of staffs that we are using for the Ministry of Health work with regards to TB testing. We are also supporting development of data system, and among them is the KNECAS PT online reporting system, which is underway, and soon we are hoping to start a pilot. So this is a platform that will support the counties to be able to report the PT results online, rather than reporting on, on a manual system. It used to be there for the Gene Expert, but it has been expanded to accommodate the new WRDs and also the PT microscopy that was currently rolled out. We are also, so there's a remote logging, TB remote logging system that has been going around. We've scaled up in 10 counties in Western Kenya, and that represents a coverage of about 58. And through this activity, we also focused on the viral load testing sites that were previously used for remote logging for HIV, and in terms of capacity building for this lab within the counties. So what NTRL does is that they trained the TOTs at the national level, as TOT at national level, then escalated the training to the super users and the county staffs to ensure that the scale-up is going on. With regards to guidelines and SOPs, this is with regards to new SOPs that are coming up based on the new scope of test. NTRL has also been critical, and one of the major achievement is that we recently developed a NTRL Lab Network Operational Plan, which will be running from 2023 to 2028. It was launched recently together with the National Strategic Plan, and we are looking forward to start looking on a dissemination process to the counties and also helping counties to adopt their own operation plans with regards to the scope of work they are doing. So on matters training and capacity building, NTRL has also been built with regards to capacity on PT production. A team of NTRL staffs were also taken to South Africa to train on how to produce PT. And right now we have trainers within NTRL who can help us in scaling up these PT production activities. With regards to challenges and limitation, a number of observations that we've made is that we are concerned with the human resource capacity. This is across the reference labs. Is that at NTRL, we might say that the workload is quite huge and the demands of the services for that staffing is actually huge. For KEMRI Kisumu, we are also looking forward that this is also potentially donor supported with regards to staffing, and we are concerned that for sustainability, these are areas that we would wish to be supported and ensure that we have a sustainable way of ensuring these staffs are existing. Increased demand for PT. Right now, we know there's a lot of scale-up with regards to the new diagnostics, and NTRL is also called upon to ensure that each test that is being done out there have a PT material to ensure that quality is checked. We are looking forward to be expanding that one together with NTRL, and the focus has already shifted to actually taking over the PT TrueNut production within NTRL. That will be a major plus for our local sustainability. With regards to accreditation and lab quality continuous improvement, we've also been supporting the NTRL and the KEMRI labs with regard to accreditation scopes. However, what is coming in critical is that we are now pushing laboratories to be accredited with KENAS. So KENAS has also come of age, and now they are capable of conducting, supporting accreditation locally within the country. But for the county laboratories, we are also looking forward to the recently launched LCQY guidelines that will be helping laboratories within the counties to also ensure that we have some element of quality checks within the counties. With regards to capacity building, the new advanced molecular testings are coming up, and these labs that are currently helping us in advanced testing, that is the national labs, we are also looking forward to ensure that they have capacity with regards to performing those new testing. Among them is the gene sequencing and also the phenotypic DST for the new regimens that are being currently rolled out. And we want to ensure that we have capacity within these labs to test that, to ensure that services are available. With regards to BSL-3 certification, it's also good to note that currently in Kenya, we don't have capacity for biomeds to do certification of the BSL-3 laboratories. We are relying on vendors from other countries, and this is an area that I think as partners we are looking forward to ensure how well can we go about getting local engineers certified to help in certification of the biosafety level 3s. So that's an area that we are still not very strong, but we are working hard towards that. With regards to areas of improvement, we've also looked at improvement of data reporting and surveillance system, and with regards to that, NTRL is currently working on an element of incorporating a dashboard for the regional labs that are doing surveillance, and those are the KEMRI Kisumu, Kilifi, Kitale.
plan and national strategic objectives. And so you will see for the NSP 2023-2024 and then to 2027-2028, some of our sub-objectives fall under the main strategic objectives of that particular NSP. As mentioned, we have some additional support within some counties, and I'll just mention some of these counties, including the USAID TBAC regional counties that include Meru, Isiolo, Tharaka Nithi in Upper Eastern. We have Mombasa, Kwale, and Kilifi in the coast. We have Siaya, Homa Bay, Migori, and Nyamira in Nyanza Western region. And then, of course, we have Nairobi County. We also have PPM-focused counties that mainly implement the workplace model. And these counties are 10. They include Kajiado, Kericho, Kilifi, Kisumu, Laikipia, Machakos, Meru, Mombasa, Nyamira, and Nakuru. Now, for these particular counties where we have additional presence, we work directly with the CHMTs. We have memoranda of understanding with which we develop regional or county work plans, and then we implement that alongside the counties. I'll mention a little bit about TIFA as a new area that we will be supporting in this year. I had a few of the previous presenters mention the INTP, which we were implementing between April 2022 to June 2023. This project ended in June 2023, but we have been able to integrate the main interventions from that Introducing New Tools project model into the TBAC activity. So let me just give an overview of what this covers and what are some of the results that we were able to see. I know I had Benson trying to answer some questions, but I think I'll add on to what it is that he was mentioning. So in the INTP, we had the first intervention, which was the use of digital adherence technology. This one was focusing mostly in Nairobi and Mombasa counties to support the two counties, because those are some of our, at the point of initiation of this project, these are the counties that had the highest proportion of loss to follow-up. These are also urban counties, and we needed to prove whether digital adherence technologies can actually work in reducing loss to follow-up by increasing adherence to TB. And that is what, that was the first intervention. The second one was the TBULIMS connectivity project. This was a national level intervention, and this one was focusing on developing a platform where all diagnostics, including gene X-ray, the new digital chest X-ray that we introduced in the last 1 year, and others like the chest X-ray, did I mention, sorry, TrueNut as well, onto one platform where we could be able to actually review and have a dashboard from which you could view all the diagnostic solutions. And then as far as lab and diagnostics is concerned, we had TrueNut that was rolled out in 33 counties. And I'm sure many of the counties represented here have at least one TrueNut machine. We have quite a number of lessons we've learned from just, it wasn't really piloting, but this was the first time that we were introducing TrueNut in the country. And some of the lessons learned are the ones that other stakeholders, including AMREF through Global Fund funding, will be able to roll out and into the country. Then we had IGRA. This was being implemented in Nairobi. Initially, the plan was to implement in Kajiado and Nairobi counties. However, only Nairobi was able to pick that up, and I'll share a little bit about that. And then we had the shorter TPT regimen, the rifampicin isoniazid regimen that USAID had supported in country, and this was also being rolled out across the 47 counties. After that, we also received additional resources to, as a country that is, to roll out the shorter rifampicin isoniazid regimen, and that is still ongoing. And then, of course, we had the 7 digital chest X-ray machines, the 8 digital chest X-ray machines that are in 7 counties, and I'll share a little bit about where exactly those machines are located, why those sites were chosen, for what purpose, and then also the results that we were able to realize. So that is why that is what we were doing under the INTP, Introducing New Tools project that was funded by USAID. And the reason why Kenya was identified is because Kenya, of course, as we know, is among the 30 high-burden countries, and we hope this is a position that we can lose very fast. It's not something we should be proud to say over and over, but importantly is that Kenya was among 11 other high-burden countries that had been prioritized for the rapid rollout of these new technologies. Now, in our first sub-purpose as a project, we focus on increasing timely use of TB, TB-HIV, and drug-resistant TB. And in the year 2023, we were able to support case-finding activities, including the ACF data review and experience sharing workshops. We were able to support PQE technical assistance missions. And then in the counties where we have additional presence, that's 11 regional counties, we were able to target high-risk groups such as health workers, persons living with HIV, and children, using the AI-enabled digital chest X-ray. And of course, through this, we were able to find quite a number of new cases. The graph there shows the ACF cascade, focusing on the workload in those outreaches. And remember, the outreaches were based on areas that were identified with significantly high-risk groups. And I'll share a little bit about that later. Then we supported the National TB Program to conduct technical assistance in various counties, and this was done in the months of January, April, June, October, November, and also December. Various counties were supported, and the list is as indicated. And then, of course, just to mention a little bit on what we do as far as deep dive county support is concerned, where we have regional presence, and like I mentioned, the 11 counties, we were able to support supervision where our regional officers, working closely with the county coordinators for TB, were able to visit the number of health facilities that you can see up there in the various regions where we have presence. Capacity building is an area we continue supporting, and we do this using various models depending on what it is the needs are. So we've done this through CMEs, sensitizations, trainings, DRTB, clinical review meetings, and by December 2023, we were able to support the training of 17,000 health workers. And then, of course, in terms of coordination, in our counties of deep dive support, we ensure that we support coordination so that then we can have the TB-HIV stakeholder forums, the technical working groups, gene expert working groups, sub-county data review meetings, as well as the quarterly county implementing partner and stakeholder forums, because this is a way of leveraging support, identifying what other partners are doing so that then we can meet the needs of the counties. Additionally, in terms of logistical support, we support distribution of recording and reporting tools, redistribution of anti-TB medication where required, facilitation of county support supervision, as mentioned earlier, as well as commodity security meetings within the counties. And then, of course, for technical support through the 4 regional officers, we continue providing supervision, as mentioned earlier, developing a consolidated regional or county work plan that puts together all of what the various partners are doing. On ACF, we supported quite a number of PQE activities, including a TA that occurred in August in 10 pilot counties. We also were able to put together the review feedback and share that for future recommendations. And then, of course, now moving to digital adherence technology, which is something I mentioned was taking place in Nairobi and Mombasa counties. To begin with, we were able to engage over 228 facilities. This was about 64% of the health facilities that had been targeted in Nairobi. We were able to enroll 4,265 patients. We had been tasked to enroll over 5,000 patients. However, we had challenges because a few did not have mobile phones. We had children under the age of 15, and we were mostly targeting persons, targeting adults. Enrollment was mostly among men, and that was a good thing. And then, of course, most of the technology used was led by the patients, and then a bit of it by health workers. That's about 33%. Looking at the treatment outcomes for Q4 2022 and Q1 2023, we were able to note some improvement and also uptake of the intervention with an average of about 57% adherence scores. Remember, as a country, we do not really record adherence. On the most part, we look at the end product, which is either treatment completion, success rate, or loss to follow-up. So this was something new where we could actually track on a daily basis, is this patient actually taking their medication? And using a phone, they would be able to use a USSD code to mention that they have taken their drugs, and then the health worker would be able to track that using the actual platform. So what we noted in terms of lessons learned is, one, this intervention was able to enhance provider-patient interaction in a person-centered way. One of the things we are not very good at in TB programming is providing solutions that are very patient-centric. As you know, a lot of our care is generic. Every patient in intensive phase must come to the facility after every week, in continuation after every so often. But using this modality, one of the things we were focusing on is the health worker and the patient agreed on when is the best time for them to come for their medication, how often, yes, does this patient require additional support, maybe using a community health provider taking the drugs to them. And what we noted was that interaction really improved the patient-centeredness of care. The next thing was, of course, leveraging and increasing differentiated care interventions. And this is where we are going globally towards providing patient-centric care. And then, of course, what we noted eventually was there was an improvement in the treatment outcomes. Then on PMDT, we've continued to work closely with the National TB Program, providing technical expertise in review of the WHO recommendations on the new DRTB formulations, and we've been able to continue providing TA in the Committee of Expert meetings, as well as the workshops to review the PMDT guidelines. We've supported TA in 3 counties, as well as CMEs in 11 counties of focus. We also continue supporting clinical review meetings for our DRTB patients to ensure that they receive holistic care through a multidisciplinary team. And then for those who require ECG, in order to monitor the adverse events, we ensure that we give reimbursement for ECG. And then, of course, for all DRTB patients, we working closely with the Lancet laboratories in 47 counties, we are able to ensure that we can support monthly baseline and follow-up, the baseline and monthly follow-up lab requests. And then, of course, we support referral to the reference labs and provide TA in various counties. On the drug resistance survey that the National TB Program is looking at initiating very soon, we've been able to provide technical support in developing the protocol alongside our colleagues from the NTP, supporting the budgeting of the survey, capacity building of the research assistants, and then procurement of various commodities that will be specifically utilized during the DRS. And then, of course, providing logistical support for training of our PI, the head of program, as well as NTRL staff. On childhood TB, again, we provide support through the COEs, as well as reviewing the WHO guideline, which needed to be reviewed for the country. We were able to support the engagement of a consultant to adopt the WHO guidelines to what it is the country requires, as well as to develop IC materials for what the country will be using. And then on capacity building in childhood TB, we've supported TOT trainings for childhood TB focal persons, as well as trainings within the counties. Now, on Gene Expert, I think this slide is misplaced. I'll mention it when we are discussing diagnostics. Yes. So on diagnostics, on our output 1.2, this is on expanding and strengthening diagnostics. We continue bundling the 248 diagnostic tests that are in the country, as well as to support the National Diagnostic Committee of Experts. We also support the 51 gene expert super users that are placed in the 47 counties to ensure that they support the various gene expert machines. And now that we have the additional 33 TrueNut machines, that they continue providing that sort of support. And then, of course, we've been supporting various engagements towards review of the lab user manuals, as well as refresher trainings for AFB and gene expert testing. Additionally, we were able to support the diagnostic network optimization exercise. This took place in June, as well as the diagnostic network assessment, which occurred in August 2023. We continue supporting EQA across the 47 counties through reimbursement of the transport costs and lunches and so forth for the various coordinators who take part in this. And then, of course, we supported TA missions by NTRL towards the LPA sites that are located in the country. Then, of course, I think these are additional activities that we've been able to support. I would like to mention a little bit on TrueNut as one of the various interventions that we had under the INTP project. As mentioned earlier, we have 33 TrueNut machines that are located in the various counties. And TrueNut was brought in country as a testing platform. First of all, a molecular test that is approved by WHO, but more importantly, one that is battery operated, meaning it's useful outside of health facilities, can be used in hard-to-reach counties or areas, and can also be used for outreaches. And so this test has been extremely useful in the last 2 years when we've actually been able to implement this. Just looking at some results from the uptake of TrueNut testing in the country between July 2022 and September 2023, this is a period when we've had the testing being validated. You can see that, one, there has been an upward trend, number one. Number two, that the general positivity rate has been between 10 and about 15% across the board. And then number three, that on the most part that we've increased case finding, especially when we had challenges with the gene expert cartridges. Interferon gamma, as I mentioned, was another NTLD-P. This one was mostly being implemented in Nairobi County, and working closely with the county, we were able to actually get significant results from this one. There were quite a few test kits, and so we were only able to implement that for a short period of time. But this is what we saw as far as the results were concerned. Number one, we were targeting mostly health workers and contacts with tuberculosis. The positivity rate for IGRA testing was between 37 and 57%. What this means is that within the population that we were actually testing, that majority of them have latent TB infection, because that is the role of the IGRA testing. And as you can see how many of the tests that were done were positive within Nairobi, and then of course how many were negative and so forth. Then focusing on the digital chest X-ray, another intervention under the INTP project. Again, this one was to introduce easily portable devices that could actually be used to take a chest X-ray. Number one, they're digital, meaning you're able to get the interpretation of those particular X-rays at your desktop. Then number three, the fact that they are portable means that they can be used for outreaches in hard-to-reach areas and so forth. And the main purpose was to detect TB in hard-to-reach populations that had issues to do with barriers. We had eight facilities that were targeted, and working with the NTP, we identified various facilities based on specific needs. So for example, we had one in Turkana that was prioritizing the refugee population and immigrants. Number two, we had one in Siaya focusing on high HIV patients and the fisher folk. Then we had another one in Kisumu. This one was focusing on high TB HIV and a faith-based organization. One was in Mombasa, focusing on urban slums and persons who inject who use persons who inject, I've lost that acronym. You know what I mean, right? Who inject drugs. And then, of course, in Kitui, we were focusing on a hard-to-reach facility with high TB HIV. In Meru, a high TB and DRTB area. In Nairobi, a chest clinic that is also considered a referral site. And then in Mathare North Health Center in Nairobi, an urban informal settlement. So that is why the digital chest x-rays that first came into the country, because this was the very first time we were implementing this, they needed to go to places where we could come up with an algorithm that works to actually increase case finding within very specific populations. As a result of this implementation, we've been able to see great results, and I will not go through these main activities that we went through, but what we noted is that, one, we were able to increase case finding where we had those particular x-rays. So looking at some results, we had over 50,000 persons screened around those particular machines. Out of those, over 4,000 screened positive. And what we were using was a cutoff, a threshold of 60, a CAD score of 60, that would indicate that this patient was presumptive for TB. Out of those who screened positive, we had over 3,000 who were tested for TB, and out of those, 30% were actually considered bacteriologically confirmed, and another 1,000 clinically diagnosed. So in total, we had about 2,000 patients who were diagnosed from those who were initially screened. This is a high yield in any setting. And so what we have found is digital chest x-ray is actually extremely useful in ensuring that we reduce the number of tests that we do, because what it has been useful in doing is actually identifying patients who are presumptive, in the sense that first they are screened using the chest x-ray, and then based on the results from that chest x-ray, then we move them to testing. And the lessons that we've learned, we've been able to share with the National TB Program, with the various donors who are looking at procuring additional resources for this country, including Global Fund, which will be supported through AMREF, and then we know there are other machines that will be coming through USAID and other US government partners. Our sub-purpose 2 focuses on raising awareness and demand creation. And what have we been able to do in the year 2023? One, through our stakeholders, including the Stop TB Partnership that we fund in some way, we've been able to engage county political health leaders, particularly on health financing for TB, ensuring that we prioritize TB within our county integrated development plans. This is extremely important because we know that on the most part, TB is viewed as heavily funded, yet there are some areas that are crucial for counties to actually pick up, you know, things like community health promoters, areas to do with malnutrition and so forth, where counties can actually make a significant contribution. We've also supported the MTEF stakeholder engagements, as well as supporting the parliamentary caucus and so forth. And additionally, we were able to support representation at the UN General High-Level Meeting last year. Moving on, I'll move to the PPM area. First of all, on demand creation, of course, we also engage social media users, and we've been able to reach over 10 million social media users in sharing TB messages. We've also been able to reach over 17 million people, focusing on empowering them with TB success stories through TV, radio, and so forth. And then, of course, printing over 1,000 IEC materials that have been shared within the counties. Additionally, we've had 2 TB infomercials. I don't know if anyone has seen a TB infomercial on TV. Anyone? By show of hands? We don't watch TV these days, eh? You've not seen some actors talking about TB in a funeral, something like that? Anyone? By show of hands? Aye, clearly we don't watch TV. Ama? Okay. Chair, naona tutafanya energizer. Yes. And then, of course, planning and commemorating. We need an energizer. Okay, we continue. All right, and working closely with the National TB Program towards developing a TB newsletter that we work on every quarter. Then, of course, on PPM, as you know, we had developed various PPM models, I think in 2013, and following development of those models, NTP was able to adopt them. That includes the chemist and pharmacy model, we have the informal service provider model, we have the lab model, and of course, engaging individual private providers as well as institutions such as hospitals. Currently, we are implementing the workplace model. First of all, the models that were introduced in 2013, 2014 have been adopted as routine, and we have Global Fund supporting the rollout of those models in the 47 counties. As USAID TB Act 2, we are supporting the workplace model because this one is not supported by any other partner, and this is where we actually systematically engage workplaces in TB prevention management, TB prevention and management, and integrating TB services within the health programs at various workplaces. Number two, we focus on workplaces that have a high male proportion because we know that on the most part, and according to the prevalence survey, we were missing a lot more men than females. And so we try as much as possible to identify workplaces where we have a congregation of men. And then, of course, we've engaged various counties, as I had mentioned earlier, including Nakuru, Kericho, Mombasa, Kilifi, Kisumu, Nyamira, Meru, Laikipia, Machakos, Kajiado, and Nairobi County. And we are looking forward to scaling this up even as we end our project. Looking at the results, we've already mapped about 478 companies in those 10 counties where we have presence. We've mapped these companies by county, as indicated in the second slide, and many of those companies actually have a clinic that is located within the organization. And so we target and map to see how many employees are within each of those organizations. And then with a bit of modeling, we are able to target and say, how many TB cases are we likely to get from these particular organizations? So far, we've been able to engage 136 workplaces, and we've had various processes where we've conducted TB awareness sessions, sensitization, capacity building of organizational nurses and so forth, experience sharing with them, as well as making sure that we have a sustainability approach towards the way we engage these particular workplaces. So identifying champions and so forth. And then, of course, working with the NTP, we are using Tibulite to actually ensure that we input the workplace data. Looking at the cascade in terms of the workload from those 136 workplaces, we've been able to identify about 336 new TB cases who would have otherwise been missed within these particular workplaces. And this for us is a win and something that we feel can actually be scaled up. Then on the last sub-purpose, which focuses on efficiency and sustainability of the NTP, to begin with, we support the strengthening of the policy framework and resource management. Here we are able to support supervision for the various coordinators within the counties to ensure continuous high-quality supervision for the facilities that they engage with. In coordination, we were able to provide support for 2 workshops towards NSP development, as well as a consultant who was supporting the NTP in NSP writing. We also provided technical support for the Global Fund grant writing, and we had team members engaged in various teams. We were able to also support various counties that had done manuscripts and had successfully submitted manuscripts for the PATS conference that took place in June this year. And then, of course, working with the NTP, we've been able to work on development of the multi-sectoral accountability framework. I think I'd mentioned a little bit on TrueNat, IGRA, and the connectivity platform, looking at various areas of strengthening the policy framework, so that while these was in 2022-2023. This was phase 1, you know, like a pilot of sorts. We've learned a lot of lessons that we are looking to share for the next round of funding, where other stakeholders will be coming in to beef up these particular solutions. The connectivity platform has expanded and now is able to document and show on a dashboard not only GeneXpert workload, GeneXpert uptake, and so forth, but also TrueNut, and now we have the digital chest X-ray that is able to be monitored on the connectivity platform. On commodities security, this is not a direct area of support, but we provide technical support within this particular fora to work with the NTP to ensure that commodities are available as required, and also to support emergency drug distributions. And then, of course, we've been able to provide airtime for coordination of the National Order Management Team. Other technical support that we've been able to provide, of course, these are just pictures of various platforms where we've had presence and provided technical expertise, and we are happy to continue partnering in that way. And then on data for decision making, under TIBU, we've been able to support license renewal and so forth, as well as other activities that have been done under monitoring, evaluation, and learning. And then finally, on operations research, we encourage the counties, on the most part, to document a lot of what it is that they've done. And in the last year, we've been able to support various individuals to actually present their abstracts that were accepted, oral abstracts, in various platforms. As mentioned earlier, we had the PATS conference in June, and then, of course, the Union conference in November. And then, as we are closing the project in September, we have received an approval of the TBAC protocol to actually conduct a lot of operations research on various models that we've been able to implement through USAID support. And this is something that we'll be reaching out to various individuals in the counties and at NTP level to actually document what we've done. A new project that is actually coming on board is the TB Cross-Border Project. This is a USAID-funded project that began on January 15th this year. And this particular project focuses on strengthening cross-border coordination between the Kenyan and Ugandan border. So this particular project is focusing on hard-to-reach borders like Turkana and West Pokot. Then we have other border points like Trans Nzoia, Bungoma, and Busia, and then wet borders that include Siaya, Homa Bay, Kisumu, and Migori. So we have 3 TB commitment grants that include the counties that are on board. So if you see, I'm sure for those who are, you know, one of the counties that is supported under this particular project, we have already worked together towards developing the work plans that were approved by JSI. We are a sub-recipient of JSI that is funded by USAID. So this is something that is new, something whose first stakeholder forum will be taking place next week, March 4th, and one where we will be brought together by the key implementing partner, IGAD, towards bringing various stakeholders together. Our project coordinator is Dr. Washira. I don't know if he's here, but I know he has worked alongside Tomno, who is the lead on the NTP side of things, towards reaching out to the various counties and ensuring that we are all engaged. And then as an organization, CHS as an organization is looking to go into new areas, including aligning TB and HIV programming towards primary healthcare, and we were able to support one workshop towards the role of integration in converging vertical programs into primary healthcare. And this is something that we were happy to bring together various experts, including Dr. Omesa from WHO, Dr. Kadure from NTP, and many other experts in this particular plenary. So for us at CHS, funded by USAID under the TBAC2 project, our commitment is to continue providing logistical and technical support in all areas within our scope, which include TB, TB-HIV, drug-resistant TB, both at national level and then where we have presence, to continue working directly with you within the counties where we have been mandated to support. And this includes the 11 high TB, TB-HIV counties, the 10 PPM counties, and now we have the additional 9 counties under which TIFA will be implementing. Our approach, as always, is very collaborative, where we work together towards finding solutions that work for where we are present. And then, of course, where we have additional presence, we focus on, 1, aligning to the National Strategic Plan, but then number 2, testing new models. And that's how we identify models that work, that show results, and then we share those with the NTP for rollout by other stakeholders that include Global Fund and others. And then at the end of the day, our goal, just like the goal of the National TB Program, is to reduce the incidence of TB and reduce deaths due to TB. Thank you very much.
Thank you very much, Dr. Lorraine. Let's have a coordinated clap as we appreciate the work that the TB Act team, 2 team has done. Haya, Pasha, Panua, Panua tena, Rembesha, Angusha. Thank you so much, TB Act 2 team. So we'll take a round of questions. Let's see, from the farthest row. I need a mic. Oh, okay. Valerian has, okay. So, a round of questions, clarifications, comments for the TB Act 2 team. Okay, there's one here. Valerian, right here, the 3rd row. We'll start with Lodi, then we can go to Yego.
Thank you very much, Daktari. I think you have done a great job. We want to thank the TB Act for supporting us in many ways. The work that was shown yesterday by the TB program is because of the support we get from your organization. 2 things. Na yangu ni pesa tu. I'm going to ask about money. I know it's not very comfortable, but that's what I'm going to ask. Number 1, the trainings in the counties. I don't know about my colleagues, but for me, I've had challenges with the trainings at the counties. Sometimes tunaambiwa mna train hii week na mwanze mapema. Alafu courts naletwa. Alafu kitu ingine ni mambo ya train from your facilities. And there are 2 challenges there. My main facility is Bungoma County Referral Hospital. It has got 2 halls which they use for patients. Sasa, I'm supposed to use those halls. Now, kule sahi, lazima ulipie. Facility improvement. Unless you are a member and the activity is from the facility itself. So if you are you say ni TB Act, mtalipia. Ukisema dumisha afya, utalipia. So as you plan the trainings at the county, vile mnatutreat hapa vizuri, mnatupea hii maji na vitu zingine, pale county, wale ile results tuliona jana, ni wale watu, the healthcare workers. Please, let's also treat them well by giving them a conference package. And also issue about stationery. It's never included. Sometimes nasema ni 5,000. Sasa 5,000 utaanzia wapi? Hotels sometimes kama hii training ya mwisho hii ilikuwa ya National TB Program. Dr. Kathure yako hapa. Ile ya children. Tulikuwa na shida sana. Getting a hotel, problem. Getting from the facility, problem. Transport in kidogo. Ya mwisho daktari ni pesa. Hii sasa hii ulikuwa rafiki wetu kabisa wa karibu, lakini sasa ahadi yako hujapeana, huja meet. Unatusupport tufanye support supervision. For 3 years umesema uta improve. The sub-county TB coordinators unaumia sana. Especially those counties naitwa easy to reach. It's no longer easy, daktari. It's very hard to reach those easy to reach. With 500 shillings inakuwa ngumu kabisa. Sasa hiyo promise umefanya for 3 years, Tafadhali sasa honor it. Sandeni sana daktari.
Thank you,
Yangu ilikuwa
Lodi.
tu juu ya pesa.
Your concerns are noted. Ruben?
Thank you very much for this chance. My question is, but before I ask the question, I want to appreciate the contact our country is making with our neighbors, especially Uganda, on TB issues. The question I'm going to ask is that there are patients who are farther away from this country, and an example I'm going to give is the country of Qatar. I had asked this question in another forum, and I saw an email asking us for details of foreigners who have, or Kenyans in foreign countries who have had TB. I don't know whether that one was addressing that question, but I'll ask it again today. There are Kenyans who are being repatriated from Qatar simply because they have been diagnosed or suspected to have had TB, and they are brought back to Kenya, leaving their work there. So I don't know whether anything can be done about the rights of these people, because once they land employment in those countries, they are brought back, abandoning their employment, which I think is against their rights. Thank you.
Thank you very much, Ruben. Yeah, we have a concern here. So after him, we'll allow two more so that we transition to the next presentation.
Thank you. A good presentation. I think quite some good work happening. My concern will be on what you've called the deep dive focus counties. What informs the selection of those deep focus counties? Do we have other parameters other than the CNR? Because I'm looking at what the name had to reach. We are even making these counties look more marginalized when we leave them out. That includes the counties of Samburu, Marsabit, and the rest. And like I'm told of Laikipia. The other bit is also the concern about cross-border project. Good, but I'm also concerned about the selection of that border. I'm looking at a county like Marsabit that also borders Ethiopia and to some extent probably Somalia. It's even missing in that. So for me, I'm looking at beyond the CNR ratio, what is the other parameter that worth or makes a county fit in your deep dive counties? Thank you.
Thank you very much. Okay, we have one here from CTLC, Kajiado.
Thank you, Dr. Lorraine and CHS team. So on IGRA, Kajiado also participated in IGRA. We did about 757 tests with a general positivity rate of 37.4. So we took part in IGRA. Then the other question is on cross-border, just as my colleague has said. We are a cross-border county. We border Tanzania along the entire border in 3 sub-counties. I don't know why we only picked one country. I thought in the spirit of East African community, it would have been wise to select multiple borders so that we can compare notes even as we plan to move forward. Thank you.
Thank you. So we'll have the last one from CTLC, Kiambu, then allow the team to respond.
Thank you, CHS, Dr. Orin, for the comprehensive presentation. And thank you for supporting us on a Lancet for DR patients. But the Lancet has developed one problem of relaying back the results for the patients. The email they used to send us, the alert they used to send us when you are doing DR reviews, they no longer do that. And we have tried to resend the emails for STLCs and CTLCs so that we can be able to, they can be able to confirm the results, but it has not been forthcoming. Please, if you can be able to intervene, the contractions you have with them, it will be very grateful for us to review the patients.
So we have one more, then you can respond.
Thank you. My name is Stephen Kusero, I'm CMLC Narok. Regarding workplace engagement,
I don't know whether teachers are normally benefit in that package. Bearing in mind, we currently have quite a number of cases in schools. And if yes, the teachers are included, do you have any package for the students?
Thank you. Let's allow the team to now respond.
Thank you very much for your questions. Thank you, Lodi, for that question on support supervision as well as trainings. I think on the issue of trainings, I know many times we are limited. Where is Lodi? I can't see you. There you are. Many times we are limited with funding, yes. And so for us, it's trying to identify how we can ensure that dollar is really stretched to reach as many as possible. But I think the concerns that you've raised are concerns that are, that need to be looked at. So on a case-to-case basis, we can identify if maybe for you within your county referral, you don't have a boardroom, you don't have a good way of providing a venue for your participants, we can see how to work around that. That's what I would request. So that then we don't have a blanket, response where we say all county trainings, all facility level trainings must be in a hotel or must have a conference package, because then what that would mean is we won't be able to reach the kind of numbers that we have actually reported, but we see how to work with you to identify where there are challenges and figure it out. Then on the issue of support supervision, and in particular transport, for the last 3 years, this has been an area of concern even for us. And we know that we have representation from our donors here. They've already received a proposal we shared 3 years ago during our last annual joint work planning with the head of, with the National TB program, on how we can actually increase those particular transport rates. And unfortunately, we still have not received an approval to do that, because unfortunately supervision takes up 25% of our entire project. And so that is an area that we know is a problem, we know is pinching you. We have already made a proposal severally, including this year when we had our joint work planning last week, but we have been told to hold because that approval comes from way above our team members who work with us from the USAID. And I would like to hear what Daktari, who is here, Dr. Witi is around. He can say something on that, please. Yes, as I respond to the others. Ruben, thank you very much on the question on Kenyans who are repatriated from other countries. I think that's a question from the national TB program. I don't think I can respond to that. Maybe we can engage with either Dr. Kadure or Tomno as the, focal person in that area, just to help us figure out as coordinators, if someone reaches out to us on a person who has been brought back from elsewhere because they have TB, how do we handle that? I think that would be the best way to address that. On the deep dive counties, who asked this question? I don't think I know his name. Yes. Unfortunately, we do not decide which those counties are. Those are sort of dictated for us as a project. And they are usually counties that must be aligned with the other areas that, say, our donor USAID is currently focusing on within their county operational plan and all that. So those are not counties we pick. Even in the new grant that will be coming in the future, maybe in the next few months, that is already dictated, all right? So we don't have leeway there. And that also applies to the cross-border question that you asked. Now, for cross-border, there are various implementing partners that are supporting matters cross-border between Kenya and South Sudan, Ethiopia. We have others that support, and I am not sure if they're in this meeting, but one of those partners includes AMREF through Global Fund funding. We have Red Cross also, I think funded by Global Fund, if I'm not wrong, and then we have IGAD. So you have different partners who are funded by different donors to support different cross-border issues. So we already know there are other partners that are supporting the northern border, Kenya, South Sudan, and Ethiopia. I think we were even introduced to them last week. We know there are others supporting the southern border. So I think what we can do is to see how Tomno, the focal person, can bring us together, and then we can share that outlook with the counties, if that's okay. Joseph, on Kajiado, thank you for that clarification. Well noted. I apologize, I missed out Kajiado on the IGRA testing. And that responds also to the issue of your cross-border with Tanzania. That is not our area of scope, but I'm certain there's another partner who's addressing that one. Mwangi, I think that's also an area of concern. We will definitely be reaching out to you through Kennedy, our lab advisor, to see what the issues are with the relay of those results so that we can figure out a solution. Thank you for that. And we appreciate all feedback, by the way. Then lastly, there was a question on TB in schools. I know this was an area of focus some 2 years ago for us. I also know AMREF is doing some work on TB in schools. I think we can identify how best to respond to the needs that are coming out. Yes, but I agree, this is an area that should also be focused on. I think I'll stop there, and if we have, yes.
Okay, thank you very much. I'll allow Dr. Witi to speak to the issue you mentioned earlier.
Good afternoon. Somehow you had to make me speak. But anyway, I think Dr. Lauren, you've essentially answered the question well. Not possible within this current grant. Yes, I do know, by the way, yeah, TBAC has been fighting for you to have the increases, I mean, to be commensurate with the economic times, yeah, for quite a while now. But it's not possible within this current grant. Let's see if it will be possible within the next grant, right? We do know that this is one of the things which we need to really consider. So it is one of the things which we will consider seriously in the next one. We will have a serious ask, and we will come back to you, all right? With increase or with commensurate increase in support supervision, funds for support supervision, where will the quality be? Okay, so are we able to get more quality out of this? One of the concerns has always been, we essentially are paying for glorified data collectors, to be able to use that term. Of course, I know it doesn't cut across everywhere, but we will ask for more quality supervision. All right, so I think you will be able to, or at least your representation will be able to give us some best ways to be able to ensure that even as we propose, commensurate increase in funds for support supervision, which are actually quite considerable, are we able to demonstrate to ourselves, to the National TB Program, to our office, to USAID HQ, eventually to the Congress, that this is actually worth increasing because there'll be that quality bit which is actually attached to it. Otherwise, thank you.
Thank you very much, Dr. Witi. We'll now get the final response from the head of program, Dr. Kathure. Please go ahead.
Thank you, and a big thank you to our partners, specifically the partners that have managed to make their presentations today, and to TBAC for the support that we have continued to receive as we undertake our services. I think I have responses to two issues. One is the issue of the support that is going towards county and sub-county teams. It's something we actually have been taking up right from when I assumed office last year. And as has been mentioned, it's a subject that is very keenly monitored, both at my desk and with a partner, because we are aware of the changes that we've all seen when it comes to inflation prices, changes in transportation costs, and therefore the need to make sure that we review and revise some of those budgets. So we would kindly appeal to the county teams to please bear with us. It's something that is currently beyond us, but something that we are keenly monitoring to ensure that we are able to turn around. Now, the second question on patients that have been repatriated from foreign countries. One of the things that we have noticed with time is that the Ministry of Foreign Affairs and various other organizations, including IOM, does share with the program communication on persons that are being repatriated back into Kenya from various countries, especially because of them having come down with TB, or to notify us that there were contacts either during freight, that is in the airlines, or during the course of their work, that they have had contact with TB and they're coming back to Kenya. Now that information is and will continue being cascaded to the counties whenever possible, but we'd also appeal to the counties to share with us that information, because we'd also want to see, one, which countries are these that these Kenyans are coming from, because that's an important conversation to start engaging the Ministry of Foreign Affairs on, and start looking at diplomatic conversations between countries to see how we can further strengthen TB screening, diagnosis, and treatment across the respective borders. The other issue around that is because of the discrepancies in treatment. We find that some patients are being repatriated back, having started treatment in countries that do not use a regimen that is similar to the one that we are using in country. And therefore, making sure that we have that data, and then being able to support those patients to understand what are some of the changes we are proposing in their treatment and why that is being proposed, and then supporting them to make sure that they can complete treatment and then thereafter be able to resume their work, their services, or be reintegrated back into society. So the other thing that such patients may need is once they complete their treatment, they may need a letter either from the program or through other organizations to be able to confirm that indeed that said person has finished their treatment, has been cured, and is ready to resume work wherever they were. So those are conversations that are already ongoing, and as part of multi-sectoral accountability framework and collaboration with other sectors, those are some of the emerging areas that we are noting that are of concern, but also we are seeking to indulge you as the county teams to help us identify the patients, support them, and work with them to make sure that they have completed their treatment. Another related conversation around that is the cross-border conversation. We have seen various partners supporting activities across the respective borders that we have in the country. I know we still have a gap in the Kenya-Tanzanian border. We are still seeking to find who would be able to support us, but we have support through USAID, the USG, to support some of our water bodies borders, that's in Kisumu and part of that area. We also have some support through Global Fund to support the Northern Frontier through IGAD. However, what we are saying is that this support goes beyond to just screening, but making sure that patients that are referred across, we are facilitating conversation with the teams that are in the border areas in the neighboring countries, also making sure that patients are able to complete treatment. One thing that we will notice that will emerge and is starting to emerge is the differences in the treatment regimens across the respective border points. Therefore, one of the areas of collaboration that we are seeking to have through bringing together the cross-border partners is to start engaging through IGAD and seeing if we can push to reach out to COMESA or EXA, how we can harmonize the treatment guidelines across the neighboring countries so that at one point, a patient moving from one country to another does not interrupt treatment because either they found the drugs they were using are not available, or how then can we accommodate them within the countries where they are moving to. So those are some of the emerging conversations that we'll be seeking to have. The other area of support that we're seeking to strengthen around that is diagnostics. We have realized that we have a lot of mobile populations that are crossing borders at will, especially our open borders. And that means that patients may miss being diagnosed from one end of the border, they cross over to the other end, or they come to Kenya seeking diagnostic services. So being able to strengthen either mobile mobile diagnostic services, or being able to make sure that those services are able to accommodate those changes, is the other area that we are working on. And we might be reaching out to 1 or 2 other counties to see if we can have a mobile diagnostic truck that can be able to offer comprehensive TB diagnostic services in our border points. But yes, we have a lot that is currently going on that will be rolling out to the counties, and we will be seeking your support and collaboration even as we are undertaking these services. Thank you.
Thank you very much, Dr. And that wraps up the TB Act 2 session. Let us also give them another coordinated clap, 321 claps. So let's start. Thank you very much, TB Act 2 team. We beg your indulgence. I know it's 15 minutes past 1 o'clock. We hope that you can be a little bit patient so that we can have our last presentation before lunch. We will be inviting the Health IT team to come up. And as they set up, we want to have an energizer. Please let's be up on our feet standing. And get a seat next to you. Ensure you are close to a seat. Yeah. So we will be singing the fishers of men. I will make you fishers of men. So any F word, we have all the female seats. Any M word, we have all the M seats. And Lillian is sitting, I don't know where she will be placed. So let us start. I will make you fishers of men, and fishers of men, fishers of men. I will make you fishers of men if you follow me. That was rehearsal, so we do it faster now.
Let me help you, Sila. I will make you fishers of men, and fishers of men, and fishers of men. I will make you fishers of men if you follow me.
All protocols observed. Good afternoon. Good afternoon once again. I know it is almost lunchtime, but I want to seek your indulgence that for a few minutes, I'll be able to give you highlights of the Health IT project, a brief introduction, and also to highlight the activities that the project has undertaken over the last about 3.5 years that the project has received the TB funding. And I'm doing this on behalf of the Health IT team. We have colleagues in the house. I just want to request them to have their hands up. Health IT team. So we have one there, another one there. And of course the chief of party, please just say something before I start.
Thank you very much, Hesbon, for this opportunity. Allow me to thank very much the head of NTP, the program, Dr. Kadure, the whole program that's here today, the county TB program representatives that are here, ladies and gentlemen, good afternoon. Mine is just to say something, and here I just wanted to say that Health IT is working with the TB program to ensure that we have data for decision making, and that means that we are developing information systems that will enable for data collection and data management, and looking at future opportunities for leveraging technologies that will make it possible for us to have data, ready data, almost real-time data for diagnostics and also for decision making. I don't want to say much. I think most of what I would like to say is going to be presented by Hesbon, but I'm happy to be here and to join this progressive team that always uses data for our programming. So thank you very much.
Thank you very much, Raphael. And to pick it from what Raphael has said, Health IT has been funded by USAID over the last 7.5 years to support health information systems in the country. The prime recipient of the grant is UNES, that is University of Nairobi Enterprises and Services, domiciled at the University of Nairobi. And a lot of technical support comes from the School of Computing and Informatics, given that the bulk of our work is on digital health support, developing systems, enhancing systems to be able to address data needs, right from national to the lowest level, community level. We work with a number of government agencies. We are working with ministries, departments, and agencies to be able to meet the project goal of contributing to evidence-based decision-making by health care stakeholders in Kenya. And just to be able to highlight that, in our work, a lot of our work and almost everything that we do is around health information systems. But through the USAID funding, there have been activities that we are supporting towards use of data. A very good example is this meeting that is supported by Health IT project, just to be able to emphasize the use of data in decision making. Our support goes to 2 ministries. We have the Ministry of Health, that is and then we have the Ministry of Labor and Social Protection. For this particular presentation, I'll be dwelling a lot more on the support that goes to the Ministry of Health, and specifically to the TB program at national level and also at the other levels. In our approach to implementation of digital health solutions, we are working with a number of universities. We have the University of Nairobi as the prime recipient, and our approach is that we work with other universities. We have a total of them, a total of 7 of them across the country. I will be mentioning this in my subsequent presentation. And of course, to formalize the collaborations and the engagements, we have a number of collaborative agreements at various levels. At the national level, the counties, together with the county proximate universities, also have collaborative agreements that defines their scope and how they work at the county level. In our results framework, I will summarize it that to be able to address the goal of providing or contributing to evidence-based decision-making by stakeholders in Kenya, we have 2 main sub-purposes. One sub-purpose, or the first sub-purpose, is highlighting the work that we do around system evolution. That is development of systems, enhancement of systems. There are systems that we develop them from scratch. There are systems that we get them as free and open source systems and be able to enhance these systems to address user needs at various levels. So if you look at what I have up there, the first sub-purpose that is to your left, we have the number of areas that we are looking at in terms of development and enhancement of the systems. TIBU is one of them. And then on sub-purpose 2, we are looking at capacity building of users at various levels, national, county, and also facility level, and of course down to community level. I will also be speaking to the approach that we have in terms of capacity building, where we have an online platform that is meant for building capacity, where users are able to undertake courses at their own pace. In our work, we have been able to look at the digital health ecosystem, which is provided in detail in the slide that we have up here. First and foremost, we have the collaboration between the University of Nairobi and also the government of Kenya, and in this particular case specifically, the Ministry of Health. And given that Health IT is a local partner, one of the aims of having funded this project is to see that there is always collaboration, there is partnership that is within the country between Health IT project or between University of Nairobi and also the government. And this should go beyond the life of the project because the project is for a short period of time. But then with this kind of work that has gone on over the last 7.5 years, there is a very high likelihood that the collaboration that is between the two entities will go beyond the life of the project. And I just want to reflect back, a few years back, the country was deficient of software engineers. And if you remember systems that we were using a while back, they were mainly developed by foreigners outside the country. But as we speak now, when we are talking about sustainability, we have the know-how, we have the technical skills within the country to be able to provide the required or the requisite technical skills in the digital health ecosystem. There are 6 areas that I will just mention very briefly in our work. There is the digital health infrastructure, where we have data centers that are supported to ensure that the systems that are used at all levels are available at all times. A very key component that I want to mention there is the aspect of security, to ensure that we don't have any unauthorized intrusion into the systems. We have the free and open source software. This doesn't mean that they are completely free, but we have very minimal resources that are required in terms of adopting and adapting the free and open software that we use. A very good example of this is the Kenya Health Information System, that is KHIS, or what we have called DHIS2 for a very long time. It is a free and open source software, and it has been in use in the country for a while now, close to 15 years, supporting reporting from all health facilities in the country. What I have just down there is a list of the systems that are supported, that are supporting data capture, supporting data reporting, supporting data use at various levels. And that list is by no means exhaustive. When Health IT started way back in 2016, there were only 2 systems that were supported. That is KHIS and the Kenya Master Health Facility List. But that list has grown to about 14 systems that are currently supported by Health IT project in terms of hosting the systems, in terms of providing development and enhancement work, and also building the capacity of users. And of course, the other aspect which is key is use of data. And so Health IT project is focusing on smart health data. How do we package the data that has been captured, the data that has been reported in a way that it can be used and inform decisions. Then we have the aspect of system evaluation. Systems, when they are used, there is need to be able to address user needs, and user needs are evolving over time. through systems evaluation, we're able to capture some of these user needs, and this informs the enhancement of the systems to be able to address user needs. So that is an aspect that we are addressing. The last one is capacity development to ensure that the systems that have been developed are used at all levels and the users are satisfied. Systems are as good as the users. If the users say, no, it's not working, then it means that the system is not good enough. And so capacity building here ensures that whether it is data capture, whether it is extraction of data, whether it is reporting, whatever it is that the users are focusing on, when they have a system, they should be able to have their needs met. I want to talk a little bit, just before I go to my next slide, a very important component that we have seen over the last few years. While we talk about digital health and we are focusing on technology, we are focusing on the systems, a very important component that we have also seen over the last few years is the component of the legal framework, the standards that we have. And if you look at the lowest level of my slide, we're looking at the legal policy and regulatory framework. We know that through the through the responsible arms of the government, we have had acts that have been passed in Parliament to be able to address issues of data. We have the Data Protection Act, we have the Digital Health Act, and we also have the Health Act that have been passed in Parliament to be able to provide a framework within which, even as we talk about digitization, there is the legal framework, there is the policy framework, and of course standards as well. Looking back to a number of years ago, we had all sorts of systems in the country, and it's important that we go by standards because multiplicity of systems has been a challenge in the country, and there is a lot of duplication that was taking place, and I believe that where we are now, going by standards of development of systems and deployment of systems, these challenges are being addressed. We need to have, because of the systems that we have, there is the aspect of data exchange, and therefore one aspect that over the recent number of months, or rather the last few months, there has been focus on ensuring that data is exchanged across various systems. And of course, who owns the data is also the question that has always been under discussion. And who needs to have the data, who needs to have access when we want to share this data within or outside the country or by some other users, how do we go about that? So we have the data governance framework in place, and therefore all these issues that we talk about, all these aspects of digital health have to be within a framework that so far we have been able to define within the country. The other approach that we have used, I mentioned this a little while ago, is the county proximate university model, where University of Nairobi is working together with some other universities across the country to be able to provide technical support, to be able to provide capacity building in health information systems, and of course, health information systems evaluation. And so, in working with these counties, the universities that we have grow their skills or develop their skills with time. And one aspect that we have seen over a period of time is we have faculty, members of faculty who have gotten interest in health informatics. We have students coming from computer science background or software engineering who have developed interest in health informatics over time. And then they get to now to the real world, working with the facilities, supporting the facilities, And in that process, they're also drawing a lot of knowledge from seasoned software engineers that we have within the University of Nairobi. So the county proximate university approach has a total of 7 universities across the country, and there has been a very intentional approach to ensure that the skills of faculty and the skills of students, and also those who have graduated, that is graduates, develop in health informatics to be able to support the counties where these universities are located in. Over this period of time that Health IT has been in operation, we have had 7 universities, and these have been incorporated into the project over a period of time, starting with 2017, when Maseno and University of Kabianga joined the project, followed by Rongo, together with Masinde Muliro, and the latest 3 to join the project were Chuka, Kabarak, and Technical University of Mombasa. Currently, we have a total of 34 faculty coming from the Department of Computer Science who are able to work with interns, able to work with students, and also working very closely with the departments of health at county level to be able to provide technical assistance to the counties. One of the things that we have seen over a period of time is that there has been an awareness of the much needed IT support or technical assistance right at the facility level, because most of the interns and the faculty that we have in these universities are working with users at the facility level most of the time. And there has been that awareness created to be able to provide technical IT support, technical software development or software support at the facility level. And some of these interns have had success stories, or as a project we have had success stories whereby these interns are absorbed by the counties in which they have been providing support during the period of internship. The reach to this, to the counties that within the project is having a total of 31 counties that we have been able to set foot on. But then in terms of actively supporting facilities, we have just about half of this, about 15 counties where we are actively supporting facilities through the county proximate university. I will highlight the achievements that the project has had over a period of time, not just FY23, because some of these are building over time. From when the TB funding started, that was in 2020, up to where we are. So we have had 3.5 years of operation. The project is coming to a close in September 2024, actually this year. And so one of the, a core area of support for health IT is system evolution, where we are looking at development of systems or enhancing systems to meet user needs. And specifically for the TB program, this is an area that the TBUCash upgrade started with the review of the TBUCash, looking at what are some of the changes that need to be able to be made to the system to address user needs. And working together with the other implementing partners, we have TB Acto, we have AMREF. They've been able to provide very, very valuable contributions in terms of improving the system. That was done, and just before we crossed to this current year, that was in September, and then through October up to now, we have engaged a vendor to be able to work on the upgrades following the business requirements document that was highlighting the enhancements that are required, and also highlighting the use cases within the system. As we speak, the user acceptance testing is ongoing, and I think in a matter of weeks, we should be having the enhancement ready for a full deployment. The other area that we have been able to support, not in this current year, but previously, has been the upgrade of the website, that is the program website, to be able to meet the user needs. The other one that speaks very much to use of data is the TIBU dashboard review. Those of you who are interacting with the TIBU dashboard, we held a workshop to be able to look at what are some of the improvements that are required to be able to make changes in the TIBU dashboard. And so that has been done. The requirements specification have been documented, and this is awaiting enhancement to be able to meet the user needs. In terms of capacity building, from 2020 when the project got funding from USAID, we have had the program leading the process of training on TIBU Lite so that TIBU Lite can be rolled as a point of care, a platform for use at facility level by healthcare workers. And so far, up to last week when we had the last training, that is, we've had this over a period of about 3 years, we had a total of 41 counties trained, with the county coordinators of about 33 of them. We have had sub-county coordinators totaling to 264 trained. And the number of facilities that are currently using TIBU Lite, or where TIBU Lite has been rolled out, is 2,576, with 8,339 healthcare workers using the system. I think the major question is, will this really translate into the improved outcomes intervention that we are looking forward to? As we continue with the rollout of TIBU Lite, I think that is a very critical question for us to be able to look at. Will it translate into getting data real time? Will it translate into improved use of data for decision making? So with 41 counties trained, we have just about 6 counties left to complete the whole country. And through the leadership of the program, I believe that we are going to complete this before the end of this quarter. The other approach that we have used as a project in capacity building is online learning. We have the Kenya MOH Virtual Academy that is hosting a number of courses that those who have enrolled can take at their own pace. There is no registration fee for this. What you require for this is very minimal resources in terms of having internet connectivity to the MOH Virtual Academy to be able to take up these courses. And I brought this because the TB program led this process to be able to digitize the TB guidelines. And as we speak, there are 14 modules within the MOH Virtual Academy that have been digitized to be able to targeting those who are in the TB space. Alongside the flexibility, there is the aspect of certification. You are able to get a certificate once you have completed the course. And we have worked together with the Directorate of Digital Health and regulatory bodies to be able to provide CPD points for some of the courses. At the moment, we have a total of 6 regulatory bodies who are able to award CPD points for those who have completed some of the courses. We have seen tremendous growth in terms of the uptake of the online courses. From my slide, there is a comparison that we have there, looking at January 2023, that is 1 year ago, and the progress that we have made to date. So far, we have 34 courses. Last year, we had only 22 courses. And you can see that the number of users has doubled from about 6,000 to 13,000. We have had, so far, just about 50% completing the courses that they are taking, and of course, over 3,000 are getting certificates. The number of daily users has also gone up from an average of 62 daily users last year, at the moment we have about 150 daily users, just about an increment of, rather it has doubled over the 1 year period. Looking at TB-specific modules that we have in the MOH Virtual Academy, we had this digitized, and this was happening sometimes early last year and uploaded into the system. By January, that was last month, we had a total of 828 enrollments into these TB modules with about 32% completion. And you can see that one of the modules that is leading there in terms of completion is the TB infection prevention and control module. This is data that would be very interesting to look at, why there is very high enrollment in some courses, while some courses are not having any, rather very few enrollments, and of course very almost no completion at all if you look at the last module, that is differentiated care, social protection, and TB M&E, that has had no completion at all. So I believe that this is data that working together with the program, we can look at it and be able to inform how some of these, the approaches towards promoting online courses. The other aspect that we have also supported is infrastructure. And this has been through engagement with the program on the infrastructure support needs. And so far, we have been able to procure laptops, procure modems, procure UPS to be able to support the program at the national level. And we have been providing data bundles for the healthcare workers at the facility level. Over the period of last year and this particular year, we have about 700 healthcare workers who are receiving bundles to be able to be connected to internet. As they see patients, as they use the system. And this doubled from last year. Previously, we were supporting just about 300 and 350. Again, I think this is also another important aspect that we need to look at, that is this really translating into us getting real data? Is it translating into us getting quality data from the facilities? Looking back to the days that, or looking back to facilities that are still using manual records. The last bit that I would like to talk about is data use for decision making. And in the slide that we have, over the last 3 years, this is the 3rd year that Health IT has been supporting the performance review meeting, bringing the national team, bringing together the counties and also the implementing partners and stakeholders to be able to look at how the counties are performing. I think the big question is that, is this really helping us in terms of learning from other counties? Is it helping us in terms of improving the use of data to be able to make decisions? And of course, the key aspect here is, how about treatment outcomes? Once we have seen what other counties have done, have we seen any improvement in terms of the treatment outcomes across the country? Are we having counties that were initially performing very poorly and they have increased? I mean, they have improved in terms of their performance because of the performance review meeting. So this forum brings us together to be able to look at the performance of each and every county down to the sub-county level, and I'm sure that we drill down to be able to even find out best practices at the facility level. It also provides an opportunity for us to be able to set goals in terms of the targets that we want to meet. And the question is, when we have met our targets, what next? Are we setting lower targets? Or when we have not met the targets, are we setting higher targets? And how does this translate into improved outcomes from the TB interventions that we have in the country. That is the PRM that we have held previously. And finally, as we look at data for data use for decision making, two other areas that have been supported by Health IT previously. One was recording, review of the TB recording and reporting tools, because we know that the process of data demand and data use is a cyclic process. Once we need data, this informs the changes that we need to make in the tools that we have for data capture and also data reporting. And so the project supported this process to be able to ensure that some of these tools that are used for reporting and also recording are reviewed to be able to capture data that is required that was previously not captured, or getting finer details even as we capture the data for decision making. And earlier on, there was the support for the DQA process, which I'm sure that we all are aware that DQA is a way in which we're able to look at the data. Are we having data that is able to, that is accurate? Are we having data that is able to, we can trust in it and be able to make decisions based on the data that is coming from the facility level. So the DQA process has been supported to see where the data quality or the quality of data is at, and what kind of improvements we can make to ensure that the data is accurate, to ensure that we can trust in the data, to ensure that we can use the data. And that brings me to the end of the Health IT presentation, having highlighted some of the key activities that we have been able to support over the 3.5 years. I would like to take this opportunity to really acknowledge and appreciate the support that we have got from the program, most importantly in planning for activities. The joint work plan has been a very good opportunity for us to be able to work with the program, work with other implementing partners to plan for activities, and also implement the activities together. The success that we have had in terms of implementation of activities is because of the time and the resources that have been put in planning for these activities. The other one, my acknowledgement goes to USAID that has been funding the project over this period of time. This is a cooperative agreement, and there has been a lot of, I would say, partnership, a lot of collaboration, a lot of discussions in how we are implementing, what needs to change, what we need to do well, what we need to improve on. And of course, we have been able to learn quite a lot over this period of time. That brings me to the end of the presentation. Thank you.
Nyewe mko na njaa kweli. Tayarisha vizuri. Tayarisha, 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 tayarisha. We are going to give 3 hot ones. 1, 2, 3. Thank you. Any questions for Health IT? I understand it's before lunch, but you can ask just one. All right, if there's no question, I recognize Raphael. Karibu, you can maybe say something, just say hi, greet, then we can break for lunch.
Right, so thank you very much, Doc, for this opportunity. I already said something, but I think given the presentation that has been made, there's an opportunity for us to interrogate the systems further, to interrogate the data further, and if there are any questions, we could address them to the service desk, and also be able to look at that data one-on-one to get more insights. As we see here, all the strategies are going to be data-driven, so we need to be data savvy and also be attentive to the changes in the data. Mine is just to thank you very much for listening to this presentation and for engaging and being very good users of the information systems that we have out there. Thank you very much, and back to you.
Thank you, Raphael. Thank you, Hesbon. There being no question, I'll ask JM to say a word of prayer before we go for lunch.
So we pray for lunch. Father, in the name of Jesus, we thank you for this afternoon. We thank you for being with us since morning, and indeed since the days we've been here, we thank you. Lord, as we break for lunch, we pray that you may be with us, you may bless the food that we take. In Jesus' name, we pray and believe. Amen.
So lunch is 45 minutes. We are leaving at 5 to 2. So around 2:40, we get back. Yes, vouchers, you pick them at the registration desk. Lunch is served at the same venue. Let's try and keep